Welcome to the Weekly Neurology Deep Dive, produced by Amer Gavanini. Today we're tackling something really essential, a deep dive into the safety and effectiveness data for the upcoming 2025-2026 season's immunizations. We're focusing on COVID-19, respiratory syncytial virus, and influenza. Our goal here is to give you, the practicing clinician, a fast, reliable, and independent summary you can use directly in your practice.
Absolutely. And just before we jump into the details, it's crucial to state up front. This discussion is purely for educational purposes. There's no commercial goal behind this. Think of it as a high-level summary. We're synthesizing findings from, well, an incredible 511 studies published since the last big advisory committee on immunization practices reviews. Given that volume, we strongly recommend you read the full source paper for the complete picture and all the important methodological details.
511 studies. That number alone really underscores how fast things change in this field. So let's cut straight to the chase. We should probably start with a practical summary. If someone only has a few minutes, what's the absolute key takeaway from all this data?
Right. The clinician's takeaway first. Here it is. Overall, the vast body of peer-reviewed evidence we looked at strongly supports both the safety and the effectiveness of all three vaccines. That's COVID-19, respiratory syncytial virus, and influenza. And the key outcome they help reduce is severe disease, especially hospitalization and, ultimately, death.
Okay, effectiveness is supported. Can we put some rough numbers on that? What level of protection against severe outcomes are we generally seeing?
When you look across the board, different viruses, different groups of people, the effectiveness against ending up in the hospital generally falls somewhere between, say, about 40% and upwards of 80%. Now, that's a wide range, of course. It varies based on the specific virus. Who we're talking about, effectiveness is often a bit lower in immunocompromised individuals, for example, and which variants were circulating at the time. But the consistent theme is substantial, clinically meaningful protection.
And safety, particularly from a neurologist's perspective. What were the key findings there?
Safety is paramount, naturally. We paid close attention to adverse events of special interest, things like inflammatory events, autoimmune issues, vascular problems. Let's break it down by vaccine. For COVID-19, particularly the updated XBB.1.5 mRNA vaccines.
Yes, what's the latest on those?
The safety profile remains largely reassuring. Myocarditis and pericarditis rates are still low, mostly seen in male adolescents and young adults. We're talking numbers like maybe 1.3 cases per 100,000 doses after the first shot and about 3.1 per 100,000 after the second for the BNT162b2 vaccine in males 12 to 19. Importantly, the studies looking specifically at the newer XBB.1.5 vaccines didn't find a significant excess risk for myocarditis. That's good news for the current formulations. And regarding stroke risk, most studies actually show either no significant link or even an inverse association with the BNT162b2 vaccine, meaning potentially lower risk.
Interesting. Inverse association versus no association. We definitely need to dig into that later. But first, let's quickly cover respiratory syncytial virus. You mentioned a new signal there.
Yes, that's the main new point of attention from this review. For respiratory syncytial virus, there was a small but statistically significant association found between Guillain-Barré syndrome and one of the vaccines in older adults, specifically the RSV pre-F vaccine. The estimate was about 18.2 extra cases of Guillain-Barré syndrome per million doses given. This is a clear signal we need to be aware of and discuss with older patients considering that specific vaccine. Crucially, though, the other main respiratory syncytial virus vaccine available, RSV pre-F3 AS01, did not show the significant association in the reviewed studies.
Okay, so a product-specific neurological signal for respiratory syncytial virus. What about influenza, the one we have the most history with?
For influenza, the safety profile continues to look very good. There's no consistent significant signal linking modern seasonal flu shots to Guillain-Barré syndrome. The data on stroke risk is a bit mixed, which often happens in these large observational studies. One study did show a slightly higher risk for stroke or transient ischemic attack combined in older adults, but another large study actually showed a lower risk of stroke after vaccination.
Right. We'll need to unpack those conflicting findings too. But this initial summary is really helpful. Key message seems to be, effectiveness is solid, vaccines remain crucial for prevention. But we have this specific new signal for Guillain-Barré syndrome, the 18.2 excess cases per million with RSV pre-F to incorporate into our discussions.
That's the essence of it. Now let's dive deeper into the evidence behind these points, starting with COVID-19 effectiveness.
All right, let's really unpack the COVID-19 effectiveness numbers moving beyond the summary. As neurologists, we're especially focused on how well these vaccines, particularly the recent XBB.1.5 mRNA ones, protect against severe outcomes like hospitalization and death.
Exactly. So looking first at the general adult population, the review pulled together data from multiple studies, both cohort and case control, focusing on these XBB.1.5 vaccines. The pooled effectiveness against hospitalization came out at about 46% in the cohort studies, and it was about 50% in the case control studies. Pretty consistent there.
46% and 50%. Very close. Can you just quickly remind us why we often see these two types of studies and why the numbers might differ slightly?
Good question. It's about how they're designed. A cohort study follows groups vaccinated and unvaccinated forward in time to see who gets hospitalized. It measures the actual rate difference. A case control study works backward. It finds people who are hospitalized and compares them to people who aren't controls, then looks at their past vaccination status. Case control studies are often quicker for getting effectiveness estimates, especially when things are changing fast, like with new variants. But the odds ratio they calculate can sometimes slightly overestimate the true effect, maybe due to differences in who seeks vaccination, the healthy user effect. The fact that these numbers, 46 and 50%, are so close really strengthens the finding. It suggests a robust, real-world protective effect.
Makes sense. Now, what about the groups we worry most about? Older adults, say 65 and up.
Protection holds up well there. For adults 65 and older, the pooled effectiveness of the mRNA XBB.1.5 vaccines against hospitalization was about 56%. That's really important given their higher baseline risk. And if you look at the ultimate outcome, death, one large cohort study estimated effectiveness against death at about 75% overall in that age group. Breaking it down a bit more, effectiveness against death was around 58% for those aged 65 to 79 and about 48% for those 80 and older.
That slight decrease in protection against death in the oldest group, the 80 plus, really highlights why consistent vaccination efforts are so vital for them. Even 48% protection is hugely significant.
Couldn't agree more. And that leads us straight to another critical group, immunocompromised adults. Many of our neurology patients fall into this category, perhaps due to multiple sclerosis therapies, myasthenia gravis treatments, or other conditions needing immunosuppression. What did the review show for them?
Yes, this is always a key question. We expect a somewhat lower response. What was the effectiveness against hospitalization?
For immunocompromised adults, the pooled effectiveness against hospitalization, looking across 4 case control studies, was about 37%. Now, yes, that 37% is lower than the roughly 50% in the general population. But, and this is crucial, it still represents a meaningful reduction in risk. About a third fewer hospitalizations is still a major clinical benefit we shouldn't discount. We can't let that lower number discourage recommendations.
That's a very important perspective. Did the data look at any specific immunocompromised subgroups?
It did, and the findings there are quite compelling too. One retrospective cohort study looked specifically at patients with end-stage renal disease, a group known for having weaker immune responses. In that specific group, vaccine effectiveness against death was estimated at about 61%. So even if protection against non-fatal hospitalization is reduced, there's still significant protection against the worst possible outcome.
Okay, let's talk about the constant challenge with respiratory viruses, evolution. How well did the XBB.1.5 vaccines hold up when newer variants like JN.1 became dominant?
Yes, antigenic drift. The data really highlights this issue. When the JN.1 subvariant was the main one circulating, the effectiveness of the XBB.1.5 adapted vaccines was generally lower. The range reported was quite wide, from about 14% up to about 54%. That drop, often falling below that 50% mark, is what happens when the virus changes significantly from the strain the vaccine was designed for. It just reinforces why we need timely updates, much like we do every year for influenza.
But the review also gave a hint about what happens when the vaccine is better matched, right? Looking ahead to strains like KP.2.
Exactly. There was preliminary data on vaccines adapted against the KP.2 subvariant. One early case control study showed effectiveness bouncing back up to about 68%. This suggests that if we can keep the vaccine composition reasonably aligned with the circulating strains, we should expect strong clinical protection, potentially getting back well above 50% effectiveness against hospitalization.
Before we shift gears to safety, one more practical point, highly relevant for us in neurology. Long-term symptoms, post-COVID-19 syndrome. Did the review touch on whether vaccination might help prevent that?
That's a critical question for chronic care. While most studies focused on acute outcomes, there were 2 pediatric studies that did provide some preliminary data. These studies suggested that vaccination in children was linked to a lower risk of developing post-COVID-19 symptoms. The estimated effectiveness against these long-term issues ranged from about 57% against having at least one symptom, up to about 73% against having two or more symptoms.
That's quite striking, even if it's pediatric data for now. It suggests vaccination isn't just about avoiding the intensive care unit, but maybe also about preventing those chronic neurological and systemic problems that often end up in our clinics later on.
Right, let's transition to the safety data now. And here, we really need to apply that neurologist's lens, focusing on those inflammatory, autoimmune, and vascular events.
Let's begin with myocarditis and pericarditis. The summary mentioned it's rare, mainly in young males. Can we expand on that finding about the dosing interval being potentially protective?
Yes, this is a really powerful example of how we can sometimes mitigate even a rare risk through careful protocol adjustments. We know the risk is highest in male adolescents and young adults, again, roughly 3.1 cases per 100,000 doses, after the second BNT162b2 shot in the 12-19 age group. But the key insight came from a large French case control study looking at over 80 million doses. It clearly showed that putting more time between doses was linked to a substantially lower risk of myocarditis. Specifically for the third dose of BNT162b2, the adjusted odds ratio for myocarditis dropped significantly. It was about 6.5 if the third dose was given less than 153 days after the second. But it fell to about 1.6 if the third dose was given more than 213 days after the second.
Wow, that's a big drop from over 6 times the odds down to only about 1.5 times the odds just by waiting longer. That's incredibly useful for counseling, especially young men needing boosters. It suggests giving the immune system more time helps.
Precisely. And as we touched on in the summary, the latest data is also reassuring. 2 recent U.S. self-controlled case series studies looking specifically at the current XBB.1.5 adapted vaccines found no significant association with myocarditis. That's very good news for the shots we'll be using.
Okay, moving on to vascular events. Stroke and transient ischemic attack. As neurologists, this is complex. The vaccine itself is one question, but the infection is a known major thrombotic risk. What did the review find about mRNA vaccines and stroke?
The picture for the BNT162b2 product, the Pfizer vaccine, looks generally favorable. Most of the large studies reviewed in adults actually showed either statistically significant inverse association suggesting a potentially lower risk of stroke or just no significant link at all. This covered both ischemic and hemorrhagic stroke types. Multiple large international studies back this up, often showing adjusted hazard ratios below 1.0.
I have to stop you there. That idea of an inverse association, a lower risk of stroke after the vaccine, feels a bit counterintuitive if there's any underlying inflammatory risk from the vaccine itself. Is that real protection? Or is it that healthy vaccine bias again?
That's the million-dollar methodological question. It's highly probable that a good portion of that observed inverse association is indeed the healthy vaccine effect. People who get vaccinated tend to be, on average, healthier, more health-conscious, managing other conditions better. However, we can't completely rule out some genuine protective effect, maybe by reducing subclinical inflammation or preventing severe infection, which is a stroke trigger. But regardless of the exact mechanism, the practical takeaway is strong. The data overwhelmingly indicates no concerning increase in stroke risk with BNT162b2. If anything, it's neutral or looks favorable.
Okay, but you flagged a difference between the products in the summary. The data wasn't quite the same for the mRNA 1273, the Moderna vaccine.
Correct. We need to be precise here. One specific Italian self-controlled case series did find a higher risk of ischemic stroke linked to the mRNA 1273 vaccine. They reported an incidence ratio of about 1.4. Importantly, in that same study population, they did not see this signal with the BNT162b2 vaccine.
A 1.4 times higher rate. How do we interpret that difference between the two mRNA vaccines? Is it the lipid nanoparticle, the dose, study limitations?
That's exactly what a systematic review highlights but can't definitively answer. A leading hypothesis relates to the dose and reactogenicity. The mRNA 1273 vaccine has a higher mRNA dose than BNT162b2, which often leads to slightly more pronounced short-term side effects, potentially reflecting a slightly stronger, brief inflammatory response. While this finding of an incidence rate ratio around 1.40 likely represents a small, possibly transient effect and could be influenced by factors specific to that Italian setting, the review compels us to acknowledge it. Practically, it might suggest favoring BNT162b2 if counseling a patient with very high baseline stroke risk, though the absolute risk increase is likely very small.
And what about our immunocompromised patients and stroke risk?
Here, the data is quite reassuring. A UK-based study focusing on immunocompromised adults actually found a reduced risk of ischemic stroke after the first dose of BNT162b2. The adjusted incidence rate ratio was about 0.68. For later doses and for hemorrhagic stroke, the risk remained neutral or possibly reduced. This strongly suggests that for our immunocompromised neurology patients, the benefit of vaccination in preventing severe COVID-19, a known major stroke trigger, far outweighs any potential, likely minimal vascular risk from the vaccine itself.
Let's quickly touch on cerebral venous sinus thrombosis. This got a lot of attention early on with some other vaccine types. How did the mRNA vaccines fare in this review?
Similar to the stroke data, it's a bit mixed, but we're talking about very rare events, which makes firm conclusions difficult. An English cohort study found no link with either mRNA vaccine. However, that same Italian self-controlled case series, the one that flagged the stroke signal with mRNA 1273, also reported an increased risk of cerebral venous sinus thrombosis, specifically with mRNA 1273. The incidence rate ratio there was about 4.84. Again, I have to emphasize, this increased risk was not seen with the BNT162b2 vaccine in that study. So while cerebral venous sinus thrombosis is extremely rare, this potential difference between BNT162b2 and mRNA 1273 seems to pop up across different vascular outcomes within that specific Italian dataset. The prudent advice for a neurologist might be, if a patient has a known hypercoagulable state or a history of venous clots, favoring the BNT162b2 product seems reasonable based on this signal, however rare the event.
Finally, for COVID-19 safety, let's discuss Guillain-Barré syndrome, always something we monitor with vaccines.
Generally, large multinational studies have been reassuring in the short term. They mostly showed no increased risk of Guillain-Barré syndrome right after getting either BNT162b2 or mRNA 1273. One big self-controlled case series found neutral or even slightly protective incidence ratios for both vaccines in the immediate 21 days after the shot. However, there was one finding in the review that warrants attention, particularly regarding longer-term follow-up. A nationwide cohort study from South Korea compared vaccinated people to historical controls, and they followed people for a long time, an average of 471 days. This study did identify an elevated risk associated with the BNT162b2 vaccine, reporting an adjusted hazard ratio of about 1.91. Interestingly, they did not find this elevated risk with mRNA 1273 in their analysis.
That's fascinating. A nearly twofold increased hazard ratio, but only seen in a study with very long follow-up, and specifically for BNT162b2 in that context. Most reviews focus on the first 21 or 42 days. What are the clinical implications here?
It mainly implies a need for ongoing vigilance. First, remember the baseline rate of Guillain-Barré syndrome is very low. A near doubling of a very small number is still a very small number. Second, the comparison to historical controls always raises the possibility of changes in diagnosis or reporting over time, which could bias the result. Still, for us as neurologists, it suggests that we should remain aware of a potential, though likely small, association extending beyond the immediate post-vaccination period, particularly with BNT162b2 based on this one study. It perhaps shifts the thinking slightly from just an acute trigger to maybe a very subtle, longer-term immunological effect detectable only in these massive extended analyses. #Tag3, respiratory syncytial virus, RSV immunizations.
Okay, let's move to respiratory syncytial virus. This area has seen huge changes recently, fundamentally altering how we prevent respiratory illness. We now have maternal vaccines, infant monoclonal antibodies, and vaccines for older adults. Let's start with effectiveness.
Yes, the effectiveness numbers across the board for respiratory syncytial virus prevention are really quite impressive. Starting with maternal vaccination using the RSV Pre-F product to protect the baby via antibodies passed from the mother. A pooled analysis of 3 case control studies estimated effectiveness at about 68% in preventing infant hospitalization from respiratory syncytial virus.
It was 68% in real-world studies. I recall the original trial efficacy was slightly lower, around 55%. Why the difference?
That's often seen. Efficacy from the randomized controlled trial is under ideal, strict conditions. Effectiveness from real-world observational studies like case control reflects how it works in the broader population. Both numbers are strong, but that 68% effectiveness against hospitalization gives us a good sense of the practical impact in preventing severe illness in infants. Then there's the direct passive immunization strategy for infants under 12 months, using the nirsevimab monoclonal antibody. The effectiveness data here is truly outstanding. Pooled data showed about 83% effectiveness against hospitalization in case control studies and about 79% in cohort studies. Protection against needing intensive care unit admission was also very high, around 84%. It really underscores how well direct antibody protection works in this vulnerable age group.
Fantastic numbers for infants. Now, what about older adults, those 60 and up? Respiratory syncytial virus can be very serious for them, causing lung issues, heart problems.
Equally positive news there. pooled data from 3 case control studies looking at both available vaccines, RSV pre-PF and RSV pre-F3 ASC01, showed about 79% effectiveness against hospitalization in adults 60 and older. That level of protection is critical for preventing the severe complications that can land older adults in the hospital, sometimes with neurological consequences like delirium or post-infection encephalopathy.
And for immunocompromised adults, getting the respiratory syncytial virus vaccine.
Effectiveness was estimated at about 73% overall in one case control study. However, there was a notable difference within that group. Effectiveness seemed higher, around that 73% mark, for solid organ transplant recipients, but it dropped quite a bit, down to about 33% in hematopoietic stem cell transplant recipients. That's an important nuance. While the overall number is good, the response clearly depends heavily on the type and severity of the immune suppression.
Okay, effectiveness looks strong. Now we have to address that major new safety finding flagged in the summary. The Guillain-Barré syndrome signal in older adults, specifically linked to the RSV pre-F vaccine. Let's really focus on this.
Yes, this is arguably the most critical new safety information for neurologists from this entire review. A large U.S. self-controlled case series study focused on adults 60 and older found a statistically significant increased risk of Guillain-Barré syndrome linked specifically to the RSV pre-F vaccine. The analysis estimated this corresponds to about 18.2 excess cases of Guillain-Barré syndrome for every million doses of RSV pre-F administered.
18.2 excess cases per million. That's the number. How should we frame that when talking to an older patient who's at high risk for severe respiratory syncytial virus illness? The classic risk-benefit discussion.
Framing is absolutely key. First, you anchor the risk. 18.2 per million is a very small absolute increase in risk. Perspective is important. Second, you anchor the benefit. That vaccine provides about 79% protection against hospitalization from respiratory syncytial virus, which can be devastating in this age group. Third, and this is perhaps the most practical point, you differentiate the products. This signal was seen with the RSV pre-F vaccine. The other main vaccine, RSV pre-F3 AS01, did not show a significant association in the reviewed studies. Its incidence rate ratio was only about 1.5, which was not statistically significant. This difference strongly suggests the risk isn't likely due to the respiratory syncytial virus antigen itself, but maybe something specific to the RSV pre-F formulation or adjuvant. So clinically, it gives you an alternative. If a patient is particularly concerned about Guillain-Barré syndrome, maybe they have a prior history, or another underlying neuropathy, you can prioritize using the RSV pre-PF3 AS01 product, which didn't carry the signal in the data we reviewed.
That guidance on product choice is extremely helpful. Lastly, for respiratory syncytial virus, let's revisit those initial concerns about maternal vaccination and preterm birth risk. Where does the evidence stand now?
Right, there was some early concern about preterm birth with RSV pre-AF, but subsequent data tied to updated recommendations on when to give the vaccine in pregnancy has largely alleviated this. The initial signal might have been related to vaccinating a bit too early. Studies looking at vaccination given during the currently recommended window 32 to 36 weeks gestation have not shown a significant link to preterm birth. Furthermore, these later larger studies also confirmed no significant association with other serious outcomes like hypertensive disorders of pregnancy, stillbirth, or congenital anomalies. So the current body of evidence allows clinicians to be highly confident recommending maternal respiratory syncytial virus vaccination at the right time in pregnancy. The benefits of protecting the newborn are clear without undue risk to mother or baby. #TAG4, influenza vaccines.
All right, let's turn to influenza vaccines now. Here we have the benefit of decades of experience and data. Let's quickly review the latest effectiveness findings, especially how the enhanced vaccines for older adults are performing.
Yes, influenza effectiveness always shows some year-to-year variation depending on the match with circulating strains, but the patterns are familiar. For children, pooled effectiveness against hospitalization remains consistently strong, around 67%. For younger adults, say 18 to 64, pooled effectiveness against hospitalization was about 48%, so solid protection against severe disease across younger age groups.
The picture gets more nuanced for older adults, 65 plus, where we specifically use high-dose or adjuvanted vaccines to try and boost their immune response. How do those compare?
The review confirmed the value of these enhanced formulations for older adults. Effectiveness against hospitalization varied. The high-dose vaccine showed about 53% effectiveness, the adjuvanted vaccine showed about 47% effectiveness, and the standard dose vaccine showed about 36% effectiveness.
That difference is quite stark, 53% for high dose versus 36% for standard dose against hospitalization. That really underscores why we push for those enhanced formulations in our older patients.
Absolutely. And finally, for immunocompromised adults, one large U.S. study found effectiveness against hospitalization was about 32%. Again, lower than the general population, but preventing nearly a third of hospitalizations in this vulnerable group is still a very significant clinical impact.
Okay, switching to safety for influenza, let's revisit Guillain-Barré syndrome. We know the historical context, but what does the modern data say?
The recent data here is consistently reassuring. Two large, separate U.S. studies using the self-controlled case series method, focusing on older adults, found no statistically significant link between various modern flu shots and Guillain-Barré syndrome. The adjusted incidence rate ratios were all neutral, hovering around 1.0 or slightly below. This strongly suggests that the signal famously associated with the 1976 swine flu vaccine is not a feature of the current seasonal influenza vaccines we use today.
Good news on Guillain-Barré syndrome. Now, let's tackle that tricky issue of stroke risk and influenza vaccines, where the review highlighted conflicting results. This needs careful explanation.
Yes, this is a perfect example of why understanding study design is critical. One U.S. self-controlled case series looking at Medicare data did find a small, statistically significant increased risk for the combined outcome of ischemic stroke or transient ischemic attack shortly after vaccination. The adjusted incidence rate ratio was about 1.10, suggesting a roughly 10% increase in risk in the immediate post-vaccination window. This seemed more prominent after high-dose vaccination.
Okay, a small, transient 10% increase flagged in one study design. But you mentioned a large Canadian study found the complete opposite.
Exactly. A large Canadian cohort study reported that getting a flu shot within the previous 30 days was actually associated with a significantly lower risk of stroke. Their adjusted hazard ratio was about 0.66, suggesting a 34% reduction in risk.
How can we have a potential 10% increase in one study and a 34% decrease in another? What's driving that difference?
The likely explanation involves separating the very short-term effect of the vaccine itself versus the much larger, longer-term benefit of avoiding influenza infection. We know that getting sick with influenza significantly increases the risk of heart attack and stroke due to inflammation and clotting changes. The Canadian cohort study, looking at overall risk, is probably capturing this huge protective benefit. Vaccination prevents flu, and preventing flu prevents a lot of subsequent strokes. That leads to the observed lower risk, hazard ratio 0.66. The U.S. Medicare study, using the self-controlled method which compares risk in the period just after vaccination to other times in the same person, might be isolating a very small transient inflammatory blip right after the shot, without fully accounting for the massive benefit of preventing the infection down the line. So when a neurologist puts this together, the conclusion is clear. The risk of stroke from getting the flu is vastly higher than any tiny potential transient risk from the vaccine. The net effect of vaccination on stroke risk is overwhelmingly favorable or, at worst, neutral.
That makes sense. It's about the net benefit. Finally, for influenza, let's just confirm the safety during pregnancy.
The safety record here remains excellent. Multiple studies showed no significant links between flu vaccination during pregnancy and stillbirth, congenital anomalies, or preeclampsia. In fact, some studies showed benefits. One found a significantly lower risk of miscarriage, and another large cohort study found a significantly lower risk of preterm birth, with an adjusted relative risk of about 0.83. This strongly reaffirms flu vaccination as a safe and beneficial intervention during pregnancy.
Okay, before we wrap up with the summary, we need to touch on a really practical issue, co-administration. If we're recommending 3 different shots, COVID-19, respiratory syncytial virus, and influenza, especially for older or more vulnerable patients, can they get them all at the same time? The feasibility of that single visit is key.
That's a huge practical question for clinics and patients. What did this systematic review find about giving these vaccines together? Does it reduce the immune response or increase side effects? The evidence is overwhelmingly positive for co-administration. The review looked at 17 studies on giving COVID-19 and flu vaccines together, and 5 trials on respiratory syncytial virus and flu co-administration. The consistent finding was that giving them together resulted in non-inferior immunogenicity. That means the immune response, the antibody levels produced for each vaccine, was essentially just as good when given together compared to when given separately.
Non-inferior. So the body can handle generating responses to all 3 at once without one interfering significantly with the others. Why doesn't that happen?
It's really a testament to how sophisticated our immune system is and how targeted modern vaccines are. The immune system responds to countless antigens every single day. The amount of actual antigen in these vaccines, whether it's mRNA, protein subunits, is tiny compared to the overall capacity of our lymph nodes and immune cells. While studies show you might get slightly more soreness at the injection sites if you get multiple shots in one day, which makes sense. The systemic immune responses don't seem to compete in a way that meaningfully lowers protection against any of the target viruses.
That's great news for clinic workflow and patient convenience. Are there broader public health benefits to encouraging co-administration?
Definitely. The biggest advantage is simply better vaccine uptake. Asking a patient, especially someone with mobility issues or complex medical schedules, to come back for 3 separate appointments significantly lowers the chance they'll get all 3 shots. For our high-risk neurology patients, that single co-administration visit might be the only realistic way to ensure they're fully protected against all 3 major respiratory threats heading into the season. Think about combining the high-dose flu shot, the respiratory syncytial virus vaccine, and the latest COVID-19 booster in one visit. It maximizes their protection efficiently. And importantly, the review confirmed that these co-administration strategies generally had similar safety and reactogenicity profiles compared to getting the vaccines one by one. Maybe a slightly sorer arm, but overall safety looked comparable. Hashtag tagged practical summary, reinforced conclusion.
Okay, we've covered a tremendous amount of ground today, diving into the nuances of 511 studies. We've looked at specific numbers, compared methodologies, and interpreted some complex findings. Let's bring it all together now with a final, reinforced practical summary for clinicians.
Absolutely. The fundamental message remains clear. The benefits of these immunizations strongly outweigh the identified risks. All 3 vaccines, COVID-19, respiratory syncytial virus, and influenza, offer substantial, clinically important protection against severe disease, particularly against needing hospitalization or dying from the infection. Even where effectiveness estimates are more modest, like the roughly 37% against COVID-19 hospitalization in immunocompromised individuals, that still translates to preventing serious illness and preserving function for many people.
And focusing again on the key safety points neurologists need to integrate into patient discussions for this upcoming 2025-2026 season.
The main new signal to be aware of is the Guillain-Barré syndrome association, specifically with the RSV pre-F vaccine in older adults again, estimated at 18.2 excess cases per million doses. The clinical approach is acknowledge the risk, weigh it against the high effectiveness, about 79% of the vaccine against respiratory syncytial virus hospitalization in that same group, and importantly, offer the alternative RSV pre-F3 ASC1 vaccine, which did not show this signal as an option. For COVID-19 vaccines, the myocarditis risk remains low and seems manageable, particularly with longer dosing intervals and the reassuring data on the latest XBB.1.5 formulations. Stroke and cerebral venous sinus thrombosis data are generally neutral or even favorable, especially for the BNT162b2 product, though we noted those specific signals with mRNA 1273 in one dataset that warrant consideration in high-risk individuals.
And for influenza, the Guillain-Barré syndrome risk looks negligible with modern vaccines, pregnancy safety is excellent, and the conflicting stroke data is best understood in the context of the large net benefit from preventing flu infection itself.
Exactly. When you consider the heavy burden these 3 viruses, COVID-19, respiratory syncytial virus, and influenza place on individuals and the healthcare system, the evidence on effectiveness and overall safety really underscores why immunization remains a cornerstone of preventive medicine. And for our neurology patients, who are often at higher risk, vaccination isn't just about the lungs. It's fundamentally a neuroprotective strategy by reducing the systemic inflammation, vascular stress, and direct neurological impacts these infections can cause.
Thank you for joining us for this weekly neurology deep dive, produced by Amer Gavanini. As always, remember this is for educational purposes, and we strongly encourage you to look at the full source material for all the details. We look forward to diving deep into the evidence with you again next week.